So what challenges are you all seeing in terms of real-world practice compared to the patients that are being studied in clinical trials?
Across all the setting?
Well, so I guess we could comment on, maybe settings where we're seeing more elderly patients with RCC, more comorbidities, and then separately, we can also talk about non-clear cell.
So if I had to answer that question, I would think that belzutifan in the non-trial patient is a little more challenging. Patients who might have, say, baseline COPD or, some reason to have a low oxygen saturation at baseline. What do you do when they walk into clinic with an O2 sat of 75? It usually scares the crap out of the front,
Right.
desk folks, and oftentimes they come in without symptoms. So they're having these numbers at home. So how do you manage that? Do you dose reduce? Do you hold? I've yet to have a patient get in trouble in that setting, but I probably feel like I'm reducing the dose or holding the dose more in the real world setting than we were on the trials.
Right. And are you seeing a lot of the GI side effects and as an issue for the quality of life for patients?
Not necessarily with belzutifan, not really.
I think the question was about TKIs.
Did she switch the question?
No?
Okay, I had same answer.
Yeah. I think the good thing about combination is that we used a lot of single agent, at least with VEGF TKIs. And so I think we're better at managing toxicity. So we do some drug holiday, we can have alternate schedules, we can offer, like off treatment break. We were talking about good risk patients. In Europe, you cannot use IO, so we're using IO TKI, or at least in France for reimbursement. But in good risk patient, I'm happy to achieve great response and then offer de-escalation, like drug holiday, withholding the TKI. And I think we're now much better at how we manage the toxicity, to your question. So I think belzutifan, we're still in the learning curve, but the vast majority of the toxicity we've had to handle until now was VEGF-driven toxicity or immune-mediated toxicity for which we need to be promptly reactive.
Right. Yeah, I think we're, with these novel agents having to learn new toxicity profiles. And I know we've talked about immune-related adverse events, and that, of course, involves a multidisciplinary approach when specific organs are affected. In your institutions, do you have, an IRAE team? Is it sort of managed just based on case by case?
Yeah, similar approach. TFO, we're very lucky that it's managed usually by a team that is very sensitive to a topic because it's mostly a cancer-only center. So whenever we need to reach out to GI, to pulmonology, they're very familiar with the side effect profile that I know it's not the reality in the rest of the world. When I used to train in Mexico, usually as the oncologist, you were probably the expert and the only person who was kind of understood how the toxicity would present and why certain approaches were better than the other. So I think at this point it's very important to reach out to non-cancer specific centers, to the everyday practices where we're seeing most of our patient populations worldwide. So it's very easy, I want to say in quotation marks, to manage toxicities when you're in a room full of experts. But day to day, most of our patients are not going to be in that regard. So I think experience with this type of drugs and reaching out to community practices are actually key for the patients to do better.
Right. To Regina's point, I think educating particularly ER docs is key because it's the first evaluation and first treatment that matters a lot. I mean, I find my patients often getting broad spectrum antibiotics in the ER when they don't necessarily need it.
Right.
And that's probably, with the City of Hope data, it's probably not a great thing to give. If you're looking for a response, you don't want to wipe out someone's gut flora unless you need to. So educating all the members of the, the spectrum of people they might come in contact with is probably important to do a better job of.
Yeah, and to that point, in some ways, I find myself acting a bit like a transplant doctor, where they're educating their patient. Be sure and tell every emergency room doctor, so I'm telling them all, like, I'm on a checkpoint inhibitor, right? Is there introductory salvo when they go in to talk to the ER?
No, that's a great point. I mean, some people have IRAE, like wallet cards or alerts or things so that it can say, I'm on immunotherapy and these are the side effects to expect.
And to, Regina's point where she was saying, like, some of our centers have IRAE specific treatment teams. Most places don't have
Right.
that. So I am grateful that, a lot of these organizations like ASCO and NCCN, et cetera, they have very thoughtful treatment algorithms for how to manage, just a nice list of IRAEs, which really helps a lot of oncologists who are the front lines of managing this for most patients. So it's very helpful to have all of those resources available.